in. So thank you so much for taking the time to join this evening's event. My name is Dr. Tom Price. I'm a clinical psychologist who works within the safeguarding and clinical excellence team here at HelloSelf. I'm really hopeful that today is going to be a useful session, inviting us to pause and reflect on the need as psychological therapists to ensure we're offering services that are truly respectful of and responsive to our clients and their families' culture, needs and preferences. To see so many of you wanting to kind of lean into this area, to improve your practice and to think reflexively about building safer therapeutic relationships with diverse people, families and communities during the perinatal period is really encouraging. And to that end, we at HelloSelf have brought together a small collective of some brilliant minds that I've been getting to know a little better over the last couple of weeks. These three speakers really do have some deep knowledge and roots in the area. And although we only have 90 minutes this evening, I hope that we can all benefit from their experiences and expertise. Before I introduce each speaker in turn, I did just want to caveat this evening's session by saying that developing cultural humility in healthcare while broaching sensitive and safe relationships with our patients, their families and communities, to quote one of our speakers, is life work. There's no one seminar, guest speaker or person with a different background to our own seeking support with us that can give us all of the answers. In reality, there's no neat endpoint to embodying the values and principles of a culturally safe practitioner. So we must acknowledge the need for commitment to ongoing self-evaluation, the need to redress power imbalances whilst establishing non-paternalistic partnerships with communities on behalf of people receiving our support. So thank you for taking advantage of this small window of opportunity to improve your own reflective practice and perhaps enhance the therapeutic experience of the next mother or family that you come into contact with, or the next conversation you have with a colleague or an allied health professional about a mother or a family you're working alongside or that you may be concerned about. So I did allude to this before a few other people joined, but just a bit of housekeeping. Before I introduce the speakers, you'll have noticed that your ability to speak has been muted. That was deliberate, so don't panic about that. With a larger group, we do it to aid kind of continuity and flow of the session. I'd really invite you to make use of the chat, plug questions in, and I'll be kind of inviting our panelists to kind of muse over those with the 25 to 30 minutes we have toward the end of the session. So although there won't be kind of space for reflective dialogue between yourselves and the panel tonight, we really do hope that it provides lots of useful insights for further reflection, your own supervision, clinical work, conversations with teams moving forward. So I'm going to introduce each of our speakers, and then I'm going to hand over to the really interesting people. So the first of our speakers this evening then is Dr. Rebecca Moore. Rebecca is an experienced consultant perinatal psychiatrist and the co-founder of Make Birth Better, a collective of experts who bring together lived experience and extensive professional knowledge around birth and vicarious trauma. Rebecca is a healthcare advocate who refuses to accept that 225,000 families each year start their journey into parenthood struggling with birth trauma. And alongside Make Birth Better, she's working tirelessly to help. She runs an annual birth trauma summit and is a member of the BEST study at King's College London. Rebecca is passionate about reducing perinatal trauma for all and campaigning to change how we care for patients and staff working in healthcare. Our second panelist is Leah Lewin. Leah is a perinatal specialist, educator, author, and business consultant with an unwavering passion for Black perinatal health. Leah's main focus is on the impact of intergenerational trauma, and her current projects are looking closely at the impacts of intergenerational perinatal trauma in the context of racism, stigma, reproductive injustice, and racial disparities. She aims to help resourceful people move away from just talking about things towards embracing action through the creation of pathways and relationships that might help affect change in the lives of people in the here and now, whilst also holding space for healing from past trauma. Like our other speakers, she's really keen to support people and families working through the perinatal system with a focus on high quality, equitable health and social care. And finally, before we move into the Q&A, we're going to hear from Illiyin Morrison. Illiyin is a dedicated registered midwife, author, and the owner of Mixing Up Motherhood, which is an empowering platform for mothers and families exploring their perinatal journey with an emphasis on cultural barriers and the need for advocacy. In her book, The Birth Debrief, Illiyin offers a compassionate guide for mothers navigating the complexities of their birth experiences, whilst providing insights and tools to help them process and heal. She has an unwavering commitment to maternal well-being, which extends beyond the birthing suite. Through her work with Mixing Up Motherhood, she advocates for comprehensive postpartum care, destigmatization of mental health difficulties, whilst fostering a supportive community for all mothers. She is clear that the idea of cultural safety really should not be limited to dimensions like ethnic identity, but should include, for example, the intersection with the culture of the health professional supporting the person and the organization within which that relationship sits. So without further ado, then I'm going to hand over to Rebecca for the next 20 minutes or so to give us an introduction to perinatal mental health.
Thanks, Tom. I'll just wait for you to move the deck on if that's okay. Yeah, thank you. So obviously Tom has already given me a great introduction. Thank you very much for that. And I'm really going to start by just giving a very broad overview around perinatal mental health services and why they're so important for the first 15 to 20 minutes or so. So next slide, thank you. We've really covered most of that already, so I'm not going to reiterate it. But really, in my career, I've been a perinatal psychiatrist since 1999, a very long time. And I did all my training in East and South London. And really, when I started in 1999, there really weren't perinatal services across the UK. There were very few services. There were none of the kind of networks or standards or talking about perinatal mental health as we do now. And I was really, really lucky to be a very, very junior psychiatrist working for Liz MacDonald, who was really one of the pioneers of perinatal psychiatry in the UK. And I started working for her in Homerton and really fell in love with what perinatal psychiatry could be and how important it is, not just for mum, but intergenerationally as well. And I've been working in the field ever since. So I started my career in a mermaid ward, which I always just mention because at the Homerton at that time, all the wards were named after male famous psychiatrists, apart from the female ward, which was called Mermaid, which kind of said quite a lot to me about what people thought of perinatal psychiatry at that time. But now I am glad to say it's called the Liz MacDonald Mother and Baby Unit, which is a much better name for it. And as Tom's already mentioned, I'm part of the King's College BEST research team as well. We're just about to launch in the UK in the next couple of months a UK-wide, including Wales, Scotland, Northern Ireland, survey about women's experiences of birth. So I really hope that you can signpost anyone that you're working with to that, because we're really hoping that the responses from that can drive change and make the existing services even better than they are at the moment. Thanks, Tom. I just have to quickly mention Make Birth Better. If you're not aware of us, then please do have a look and join us. It's free to join us, and we have a collective of people from all across the world increasingly, and our aim is to reduce trauma through support, through advocacy, through campaigning, and through training. So please have a look. There's lots and lots of free resources on the website as well for both families and professionals that you can use. And everything that we do at Make Birth Better is grounded in the stories that we hear from people, alongside being evidence-based as well. Thanks, Tom. And likewise, I always really encourage reflections, questions, actions, in like, what will you do? What will you change in your practice? What will you take back to your team, your service, and push for change? So please do drop any questions in the chat box, and I'd be really happy to answer those at the end as well. So perinatal mental health is really, really important for many, 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 many reasons, but one of which being it's actually really common. It's incredibly common for women and their partners and families to have changes in their emotional health, both in pregnancy and afterwards. And we know, of course, that that's not just an impact for the mum, that it ripples out and can have that kind of intergenerational effect for children as well. There's been lots and lots of really good research that has actually costed out how much the cost is of untreated perinatal mental illness. It started with a study from the LSE, which was quite some time ago. But, you know, these costs are huge in terms of actual cost financially to NHS services. But most importantly, a lot of that cost then becomes the cost for the child in terms of the impact of them having had a parent with significant untreated perinatal illness. So it really, really matters in terms of thinking about the whole family's outcome. Next slide, please. And the early postnatal period in particular is a period of incredibly high risk for a woman having some form of mental ill health. And this second quote always really, you know, I think really makes clear that point, that this period of time, you are 22 more times more likely to have a psychiatric admission than at any other time in a woman's life. If you look over a graph and you can track it out, you see this massive spike around the time of pregnancy, and the only other time you get another spike is at menopause. So the risks in perinatal periods are incredibly high. And it's important because that's not just for women with pre-existing illness. Some of it will be, but it's often a period of time where people will have the first onset of significant mental ill health. So it's really important for all women to have that extra support around this time. And it's particularly important with some diagnoses. So if somebody has a pre-existing bipolar disorder, for example, then that is a group of women that should always be under specialist care through any pregnancy. They have a very high risk of relapse, not only in pregnancy, but also postnatally. And even when women are medicated and taking medication, at least 50% will have some kind of relapse still postnatally. And I actually still talk to GPs, you know, often who don't know these kind of statistics. So it's really important that if you have somebody that you know actually not only has a bipolar, but has a family member with bipolar disorder, they are at very high risk and they should all be referred in for specialist care, really prior to planning a pregnancy, but absolutely during a pregnancy as well. So these are some of the statistics, and I think just, you know, driving home how common this is, that 1 in 1,000 women will have a postnatal psychosis. It's sometimes called a puerperal psychosis. And that tends to be women with no prior history at all, tends to occur with women in their first pregnancies. We know that for, you know, many women with postnatal depression, that they, you know, that can last for years. It's often not identified. It's often not treated well. We know that, you know, that can often have begun antenatally for people. And that's often, again, not always picked up. And big numbers of women, you know, having depression in the UK each year. The most recent estimates, you know, it's around 1 in 5 to 1 in 7 women will have some kind of perinatal mental health change. So it's huge numbers of women. And then that can have an impact obstetrically. It can also have an impact in obstetric outcomes. So it ties in physical and mental health outcomes as well. And we know that, unfortunately, this is well evidenced, and the statistics haven't really changed over many, many years, that at least 50% of women who have some change in their perinatal mental health will never disclose this. So that comes from the kind of NCT hidden half statistics, which are quite old now, but they've been replicated. So, at least half of the women will never tell anybody how they're feeling. So, this is a group that we really need to think about how we're enabling people to access support as well. Thanks, Tom. So there has been a huge investment in perinatal mental health, and I think it's really important to recognise that it is an area that has received a lot of investment, which is great, because for many, many years there was a huge inequity of care across the United Kingdom, and really the Maternal Mental Health Alliance did a lot of work around mapping out where there were services and where there were not. So when I started working, there were 3 units in London, and at that point we would take referrals from all across the country. So we would sometimes have women coming into the unit from Cornwall or from Birmingham. So the Maternal Mental Health Alliance have really done an amazing piece of work in pushing for equity of care. We're still not there yet. Northern Ireland in particular has very poor provision compared to the rest of the United Kingdom. So we still need to make sure that wherever somebody lives, they can access exactly the same services. So for some families, they're still having to have their care a long, long way away from home. And if you've got children already, that's incredibly disruptive for families. So we're getting better, but it's still not quite 100% as it should be. And I'm sure this is going to be spoken about a lot, so I'm not going to spend a huge amount of time on it. But we know that the stigma around accessing perinatal mental health services really is a double stigma as such, because it's not only the stigma of having a mental health issue, but it's also the stigma that's perceived around, am I being a good enough mum? So really, it's a kind of double whammy of stigma for people. There's often a huge fear of being referred to social services, of am I going to have my child taken away from me? I think that's probably the commonest barrier still that people will talk about as to why they didn't speak to their GP, speak to their health visitor. There is anxiety, understandably, about medications, and sometimes still people get poor advice as to what medications they can or cannot take. I think there are real issues still with navigating services for people. Sometimes as a healthcare professional, I find it hard to refer people on within the NHS. So if I find it hard, then, for somebody that has just come into the UK or has moved to a different area, it's going to be incredibly hard for them to know what is available and how do I actually find my way into this service. I think there is undoubtedly the threshold for some services has risen over the years, and that it can be hard for people to access services. Sometimes they fall between different services. I think, the cruelest thing for me over the years has been, for example, if somebody had a loss, perinatal services would discharge them because they were only set up to work with people with a child, which, if you'd already been working with somebody for 8 months, was incredibly cruel. So, things have got better in terms of thinking about certain cases, but it can still be difficult to get into services. I think we've got a lot better about thinking about families, but we're not quite there yet with partners. Some services now do offer support for partners, but not all. And I would really like perinatal services to be family focused. I think they should include the whole family in how we think about care. And as I've said already, there's still, big discrepancies across the UK in terms of what a different trust might or might not offer. So there is actually some evidence from lots of sort of recent big literature reviews that perinatal mental health illness has been increasing. There are lots of discussions about that, why that might be. It might be that we're better at detecting it. It might be about a change in demographics across the UK, but it might be, you know, also, of course, many societal reasons why people might be struggling more, why they might be geographically separated from family. But there is definitely evidence that there is a trend for increased rates of perinatal mental health cases across the UK. And that's really been fairly consistent since around 2007 now. Thanks, Tom. So we've got lots and lots of literature now around kind of rates of perinatal mental health. I guess the most we have is around depression. That seems to be fairly consistent. And actually now we have a lot more worldwide studies, which is good. So we're beginning to understand how these things might present differently across the world. But pretty much depression always seems to come in at around 10 to 20%. If people have had prior depression, will have a relapse, but there's very broad sort of estimates, which really sort of tells us that the things we do make a difference. So if we're able to put in support, if we're able to put in a treatment plan, if there's good peer support, these things can really change the outcomes for people. And what you see with depression is all the classical symptoms of depression, but you often get this sort of additional layer of doubt around parenting, mothering. There can be connection from the baby as well. So that kind of perinatal layer of additional concerns and worries, along with all the classical depression symptoms. And a lot of women, when they look back, are actually able to identify that they became depressed in pregnancy, actually. So I think we need to be much better at kind of screening for and thinking about depression in pregnancy. It often has started in pregnancy rather than just being postnatal. Thanks, Tom. So anxiety is the other thing that I think is incredibly common, and you can absolutely get a pure perinatal anxiety, and it can be incredibly severe. It often starts towards the end of pregnancy. And you can get, you know, it can change to being anxious about the pregnancy, to being anxious about mothering and the baby and safety in the postnatal period. So you often can get a classical anxiety with no depression at all. Perinatal eating disorders are still relatively rare, but it's probably, you know, just something to hold in mind. If people have had a pre-existing eating disorder, then understandably they often find pregnancy very challenging in terms of the way their body is changing. But you can get new onset eating disorders, but it's not really well researched in terms of in pregnancy itself. Obsessive compulsive disorder, I just wanted to mention because it often starts for the first time within a pregnancy. It's actually around 1%, so it's relatively common, and it can get very severe quite quickly. It's often triggered by things like, say people are told not to eat certain foods, and then they'll get obsessive about what they're eating in pregnancy, or about sort of risk of infection, so there might be sort of contamination and issues like that as well. Oh, sorry, I lost my slides there. And psychosis as well, just to mention really, because historically, even when I started as a psychiatrist, a lot of women with say schizophrenia weren't able to get pregnant because lots of the older antipsychotics effectively rendered them infertile. But now that we have newer, better medications, then a lot more people with schizophrenia, for example, are choosing and planning and having very safe pregnancies. And I actually, just as I started, had seen a lot of women that were forcibly sterilised as well, because they were told that they shouldn't have pregnancies because of their schizophrenia. But that luckily is something that is very much of the past. So just sort of thinking about the group with psychosis as well, because many more women with psychosis are planning and having children than before. I've already touched on bipolar disorder, but just to flag it up again, that it is something that is incredibly high risk in terms of pregnancy, more so postnatally. And with postnatally, it tends to be mania that relapses rather than depression. So these are really a group that I really want to see them before they've even thought about having a pregnancy, to do a lot of preconceptual planning, because typically they would be a group that would be taking mood stabilizers. So they need to have an informed decision around medication and its safety and whether they should be continuing or not, depending on their choice. So just to sort of flag that up again. Obviously, in terms of birth trauma, I could talk about all of these subjects for hours, but birth trauma, we know, unfortunately, is incredibly common. All the studies come out at around 25 to 40% of all women in the UK per year experiencing some part of their birth as being subjectively traumatic. And we know that those symptoms can then last for weeks, years. They can delay people having another pregnancy. They can have a massive impact for people. A smaller proportion of that big group will go on to have a clinical post-traumatic stress disorder. And they can also be triggered by the trauma to have depression or OCD or anxiety. So it's just another thing to sort of, if you're, working with people, to explore how the birth felt for them. Because actually still there are, in many spaces, that's not a question that women get asked. And they certainly don't given the time and space to kind of talk through what their birth actually felt like, how it was. So it's really, really important that we actually ask those questions as well. Thanks, Tom. I'm going to touch on suicide because it still remains one of the most common causes of death for women in the perinatal period. That hasn't really changed over many years. It has changed slightly. And we really have very good data about this from the Embrace reviews, which are published every 3 years, and they detail all the maternal deaths for any cause across the UK, and suicide is always one of the top causes. I want to talk about 2 cases to illustrate, how this can happen. So these are shared with these women's consent. They always ask me to talk about their story, so I will do very briefly. But the first case was a woman that I saw in clinic who had had no history of any mental health issues in her life. She was 2 weeks postnatal. Her sister was a doctor and had taken her to A&E. She was a very high-flying lawyer, first baby, and within 2 weeks, she had become profoundly depressed. She had gone to her local hardware store. She had made a noose and was planning to hang herself. And I am so grateful that her sister brought her to A&E that day, because she was the kind of case of demographically of women that do actually die by suicide. And we got involved with her. She had home treatment care. She started antidepressants. And in 4 weeks, she had no suicidal thoughts. So postnatal, perinatal illness can be so rapid and happen so quickly. Women can become profoundly unwell very, very quickly. Sally S. is actually a woman who died by suicide. She had twins, and she is sort of classical of the Embrace reports that show us she had numerous services involved, but none of them were communicating with each other. So all of them held a piece of information that when you put together the list of everything that they held, you realized that this was a woman who was deeply, deeply suicidal. But because none of them were communicating, nobody saw her in her full picture. And she actually jumped off the top of a car park at 8 months postnatal and died. So I know this is really hard to hear, but I can't talk about perinatal mental health and not talk about suicide. So we must ask about it. We must explore it. It's often very different perinatally. So the way people die is much more violent. Doesn't tend to be by overdose. And the risk is obviously significantly increased, particularly if somebody has depression. So just really to hold in mind that it is something with this group that we should be asking about every time. We should really be exploring it. And if you have any concerns, to refer on. And it's a very different demographic of women who die by suicide. They're usually older, married. They're usually upper to middle class, if you want to use that phraseology, but they're a very different demographic. So just to hold that in mind as well. And if you want to kind of understand it more, the Embrace reviews give a really, really good overview of that as well. Thanks, Tom. So obviously there are outcomes in terms of perinatal mental health. It's important because clearly we want that person to be well, but also it has an impact on can have an impact on their obstetric outcome. It can affect people's antenatal attendance. It can tie into increased risks in terms of we're beginning to understand that there might be some genetic basis to that as well, particularly with women with schizophrenia. And it's not just due to sort of social things. There is something about having a mental health diagnosis itself that has an impact on obstetric outcome. So it's really something where teams need to be collaborating with midwives and obstetrics really, really carefully and keeping in touch to see how things are progressing in terms of the pregnancy as well. Thanks, Tom. So there are lots of literature that evidences the impact of perinatal illness in terms of parenting. I'm really always keen to stress that that's one part of a whole story. So often the thing that women get most distressed about is, you know, because I was anxious, because I was depressed, will this have affected the baby? Will this affect parenting? And, you know, on the whole, I would say that the risks are very, very small. We have a lot of kind of biochemical type research that looks at kind of hormone response and cortisol response. And for sure, there can be changes, but it can be very much mediated by parenting, attachment, bonding, connection. So I think, you know, having these conversations with women, it's really important to stress that. We're beginning to know a lot more about sort of intergenerational trauma, for example, and epigenetics. We don't really have any link that we don't really know that having a mum who's depressed has any significant risk to the baby per se in terms of their long-term health outcomes. So I think it's really important to couch these one-off studies in terms of a bigger picture for people. And that's what I'm talking about in terms of the next slide, and sort of, you know, we want to frame things through a perinatal lens. So we're thinking about, you know, the family as a unit, as a whole, in a trauma-informed way, and considering the whole family and what they need, how they interact, and how things are sort of interacting against each other. You can read a lot about treatment through a perinatal lens. It's really beautiful. So if anybody wants a link to a sort of bigger document afterwards, I can send that. But it's just a really lovely way to think about things in a slightly different way in the perinatal period. I'm just going to touch very quickly on treatment because I'm mindful of time and I want to give the other speakers plenty of time to speak. So there is lots and lots of evidence around treatment. Really, you know, therapy-wise, most of the same therapies that we would use in other populations. You know, CBT, compassion focus work works really beautifully in the perinatal period. ACT can work really well. Obviously, if you're thinking of trauma, then you might be using EMDR or NET or PET. And they all have a really good evidence base in terms of the perinatal period. And sometimes that might be given antenatally as well, or in subsequent pregnancies. So really, you know, not significantly different. I guess the other strands that would be different is that sometimes we would use parent-infant therapy specifically in terms of kind of fostering connection between mum and baby. And then sometimes obviously we'd use couple therapy as well if it's, you know, about a kind of the couple and parenting, then that might be used as well. But otherwise, most of the therapies that you will use day in, day out have a really good evidence base and work really well in the perinatal period as well. Just to touch on medication, all women that want to think about or are taking or are considering medication, in my opinion, should see a perinatal specialist. They need to have a proper, informed, up-to-date discussion. And when I have a perinatal consult with somebody, it will be 90 minutes, and then I will write them a letter which contains all the most recent trials. And I really feel passionately that women should have all this information so that they can truly feel that they're making an informed choice. And sometimes even that might be with dads, because we're beginning to have some literature around antidepressants might affect sperm quality. So it might be with dads and partners as well. And I just really wanted to flag up about sodium valproate, which is on the right. That sodium valproate should not be given to any woman of childbearing age. So if you ever see anybody who's on sodium valproate who's in that childbearing time, then please flag it with their GP urgently and immediately. The reason why is that it causes terrible outcomes if it's taken through pregnancy for baby. And again, very early on in my career, I saw a baby who'd been affected by sodium valproate, which I will never forget. So please, just if you remember one drug name, please remember valproate should never be, no woman should be taking it that could potentially become pregnant. Thanks, Tom. Just the last few slides from me. Just about ECT, because it is probably most commonly still used apart from the elderly with pregnant women, which many people don't know. The lady with the lipstick is again somebody that I saw very early on in my career who had catatonia, which is an incredibly rare nowadays really disorder where people are frozen and hold poses for hours and hours and hours. And she had had a baby 2 weeks ago, and she had a lipstick in her hand, and she was standing in the room with her lipstick up like the Statue of Liberty, literally frozen for hours and hours and hours. People don't eat, they don't drink. She wasn't able to feed the baby. And she had 2 ECT sessions and she was completely better. So ECT is contentious, it's not for all, but it can work incredibly well in the perinatal period. And I think sometimes people aren't aware of that. We do have lots of new stuff coming online for the treatment of perinatal depression, which I think is really interesting and really exciting. So there's this wonder drug, Brexalone, which has been developed, of course, in the United States, but it's £34,000 per treatment. So I don't think it's anything that the NHS is going to be using anytime soon, but it is working dramatically well. But the thing that's interesting is that it's a neurosteroid. So there's now some trials going on about using steroids, which are incredibly cheap, and whether they could be given as a potential, to support people at high risk of depression. There's also some super interesting trials using steroids for trauma, where it appears to disrupt the formation of trauma memories if it's given within 4 hours of having a traumatic birth. So lots of really good, interesting new potential treatment outcomes coming out. And there is one approved in the US now, which is a nasal ketamine spray, which again, they gave it to a group of women only once, and their depression scales fell into the subclinical range and held at 6 months. So there are lots of potential new treatment options coming in terms of medication as well. Just wanted to really finally also consider partners as well, because thankfully at last there's been growing recognition about partners. At the moment, it's mainly fathers rather than same-sex families, but there are 2 big studies in place, particularly around trauma for same-sex families, which I think will really add to our knowledge and thinking about specialist care that we might give. But there is lots and lots of research about fathers, and pretty much that they can have all of the same things happen as women. Certainly the case for PTSD, they seem to have fairly similar rates to women, but they're probably even less likely to access services. So I think, again, that's why I would like services to be family focused, because partners often talk about feeling sidelined by services. And I think peer support is a really great way to involve partners in particular as well. So lots of really great stuff going on. I really want to be positive about the huge changes that I've seen in perinatal mental health services. But what we do need, which is the next slide, thank you, Tom, is much more research essentially into, what works, what doesn't work, what's the best treatment. Really how we improve access is something that I'm really keen to see. Why are there still 50% of women that aren't going to access services? So lots more things that we still need. And on the next slide, Tom, thank you. We need to think about sort of going upstream rather than just being reactive. I'd really like to see, this kind of discussions and thought about how challenging that transition to parenthood begin at school and be talked about at school and, really embedded into people's minds and thinking a lot earlier. We really are way too reactive still in the NHS. We need to get a lot better about thinking about prevention. But I did want to flag up that, there is some really amazing groundbreaking stuff going on in the UK. So we now have new maternal mental health services, which are specifically set up around trauma and loss. And they are the only services of the type in the world. And we have them in the UK. As I said, we're about to launch the birth trauma study. We've just had the first parliamentary inquiry into birth trauma. And we have new independent advocates coming into services, which are coming from the Donna Ockenden review of maternity services. So there's lots of really interesting and innovative work going on in perinatal mental health services. So I wanted to end that kind of very broad sweep on a positive note, because there has been huge change, but there is still very, very much more to do, which I'm sure is going to be discussed as we talk. Thank you.
Thank you so much, Rebecca. I mean, I didn't underestimate the challenge that I set you to kind of give us an introduction to perinatal mental health in 20 minutes or so. But you've really, for people like myself that maybe don't have a specialism or a background in perinatal mental health, it's so useful to have that context. So thank you so much. Now, I'm excited to kind of introduce Leah and Illiyin, and we're going to be thinking much more about kind of contextualizing, I guess, a lot of what Rebecca has introduced us to in the context of kind of barriers, inequity, kind of, and the work that these two brilliant women have been doing in their respective kind of fields. So I'll hand it straight over to Leah, but I am going to seamlessly transition between my HelloSelf slides and the slides that Leah's put together for us this afternoon. So do bear with me.
Whilst you're working on that, Tom. Hello, everyone. Good evening. I am Leah Lewin, perinatal specialist, educator, business development consultant. And I mean, I call myself an educator because by definition, trainers use repetition to build and develop skills. Teachers utilize curriculum and syllabus to help people memorize information on behalf of institutions. And educators focus on the development and progress of others. And that is our collective aim for you this evening. I want to support your personal development to ensure that all women and birthing people experience equitable care. So today, as we delve into cultural competency and humility in your field, particularly concerning marginalized and minoritized communities during the perinatal period, our collective objective is to highlight and provoke reflective thinking about these really complex issues and develop strategies that can enhance your practice and your patient or service user relationships, but ultimately to protect them through adequate knowledge of their experiences. So in order to provide inclusive care, we have to understand the dynamics of power, privilege, and oppression. So within the context of perinatal care, power refers to the ability of healthcare providers to influence decisions, control resources, and direct the course of a patient's care. And it encompasses both the formal authority that comes from your professional roles and the informal influences that arise from expertise and experience, but that also then leaves us open to a perceived hierarchy. Privilege in intrapartum care relates to the unearned, sometimes advantages that some healthcare providers might have over others, or that certain patients might receive based on various aspects of their identity, such as race, socioeconomic status, or gender. And these privileges can really affect the dynamic of care, including access and the level of attention received, or even the quality of care that's provided. And partnership really denotes the collaborative relationship between healthcare providers and patients, as well as among the healthcare providers themselves, how it impacts your interprofessional communication. It's built on mutual respect, trust, and recognition, or a lack of, and each party's knowledge and contributions. Thanks. So firstly, I guess understanding intergenerational trauma in the perinatal period is really key. So intergenerational trauma transmits across various generations, normally more than 3, where the collective trauma that's experienced by one then goes on to impact subsequent generations. And this can manifest really uniquely during the perinatal period and affect mothers and birthing people deeply through various ways. And you can identify them through things like post-traumatic slavery syndrome, which reflects the enduring mental and emotional legacy of slavery, manifesting in mistrust, self-esteem issues, adverse maternal outcomes, and it was defined in the newly revised and updated edition of PSTSS by Dr. Joy DeGruy. Please forgive me if I pronounced her surname wrong, but I just wanted to read a little excerpt from there. Post-traumatic slave syndrome is a condition that exists when a population has experienced multi-generational trauma resulting from centuries of slavery and continues to experience oppression and institutionalized racism today. Added to this condition is a belief, whether real or imagined, that the benefits of society in which they live in are not accessible to them. It's also defined and manifests through spiritual violence, which involves undermining a person's cultural beliefs and practices, and is including but not limited to their religious beliefs, which is really crucial during childbirth. As for many women and birthing people, this is a really significant spiritual journey and an event in many cultures. Obstetric violence. So this entails disrespectful, abusive, or neglectful treatment during childbirth and the perinatal period, which can, of course, trigger trauma. It's not limited to just the physical violence. That's a huge misconception. And the language used around it have been debated many times, but when we speak of domestic abuse, we don't soften the language to make it more appropriate for the perpetrators, which is why I continue to call it obstetric violence. So the misconception is why those who are complicit often deny or do not understand their role in the act. But obstetric violence is institutional, it's mental, it's emotional, coercive, sexual, physical, and also written. We also have the perceived hierarchy, so the implicit biases and systemic structures that position healthcare providers above those that they care for, affecting communication and care quality. I often, when I'm speaking to families, will tell them to see themselves at the top of the chain, which is very difficult when you think of the power and privilege struggle, because it's almost ingrained in us as a society to believe that those that are more educated have a higher status in life than us. I won't quote my dad, but essentially, he used to tell me when I was younger that we all eat, drink, and excrete in the same way. And I've carried that with me when I'm supporting other families. And lastly, epigenetics. So studies are starting to show how trauma can alter the expression of genes in offspring, potentially predisposing them to stress and mental health issues. But as Dr. Rebecca Moore rightly said, there isn't enough evidence or information currently available. Thank you, Tom. The impact, sorry, I did miss one thing, the impact on oppressors. So we often talk about those that have been oppressed, but we need to also understand how intergenerational trauma impacts the oppressors. And that involves recognizing the inherent connections between power, privilege, and oppression. And this awareness is crucial for dismantling like really harmful practices and beliefs within healthcare, where a business structure that developed education was simply based on a Eurocentric heterosexual norm. And it's been identified that intergenerational trauma impacts victims, descendants. There's a real lack of knowledge and awareness of the impact on the descendants of the oppressors. So if we reflect on, I really need to get the pronunciation right, Dr. de Gruy's definition of how the transmission of intergenerational trauma works, we have to then prioritize conversations about the impact on the descendants of oppressors as well, to truly understand the disparities within maternal health outcomes. Again, there are various contraindications during the perinatal period that can also impact perinatal mental health. Thank you, Tom. And we have to look at the historical context and how that impacts today. Healthcare practices have both evolved and stagnated over the years. So for Black mothers and birthing individuals, historical mistreatment and systemic racism have led to huge distrust and worsening health outcomes, as we know, based on the reports. And discussing how changes and continuities in healthcare impact these communities today can really guide us towards a more sensitive and effective care strategies. So, sorry, Tom, next slide. Social care, safeguarding, and microaggressions. Inclusive and equity. Inclusion and equity in care fosters a safer environment, and it means acknowledging and challenging our own biases and understanding the profound impact of microaggressions. Oftentimes, there's a huge stigma around even acknowledging that we have bias, and I think we need to reframe our thinking. Having biases is not a bad thing. Not acknowledging the fact that you have those biases is where the problem comes in. And these subtle but often unintentional but never unconscious, I feel like that should be removed from every form of training and conversation ever. It's never unconscious. Expression of racism or sexism can significantly affect a person's mental health and well-being. So just being able to acknowledge where that may cause limitations and how to overcome that is more important than discussing whether or not we have biases. Strategies for bias acknowledgement and management. And again, this is to provoke thought. So encourage regular bias training, not because it's for financial gain, but to promote culture where staff can safely discuss and reflect on those biases and foster supportive and respectful healthcare environments, because that can impact those working within the same team, the same trust, or even the same role and environment. So we need to prioritize being able to speak very openly and almost carefree. Next slide, please, Tom. I apologise, that font is very small. So reflecting on practice and the interprofessional relationships, as I said, building communications and the opportunity through training to have open discussions can improve the care that is offered to individuals that are being minoritized and facing these huge disparities. The ability to reflect on your own practice is essential in evolving as a culturally competent healthcare provider. And that involves engaging in continuous professional development like this wonderful evening, enhancing your interprofessional relationships to ensure comprehensive and multidisciplinary care plans, and enabling that communication that Dr. Rebecca Moore touched on earlier on today, and that are respectful of all cultures and their perspectives. This does not mean that you need to know every element of every culture and every belief or religion. It simply means respecting it. The idea of having to gauge in learning everything is a real deterrent when people think of becoming culturally competent or culturally safe. And that almost makes you complicit because you're then unable to provide compassionate care. And essentially, this is a real misconception that has become an excuse. I am not a psychologist, I'm not a psychiatrist, and I do not know the intricacies of your work. And I don't need to. I'm an educator in perinatal care and mental health. It's my job to know and excel in my field, not yours. And it's the same for you when it comes to understanding culture and belief systems. Thank you, Tom. Terrible font, I have to apologize. So I'd like you to imagine a scenario where a Black mother is in the postpartum period and she expresses concern that her cultural needs are being overlooked in her care plan. I've added a couple of questions to the screen that you can either add your answers in the Q&A or just have a think about them as you leave today after this session. But how would you address this as part of a multidisciplinary team? What, if you're not aligned with other professionals, how would you align yourself? How would you be able to express your thoughts and feelings if your views and opinions don't align? How do you navigate your interprofessional relationships to ensure the safety of your client when there is a lack of diversity? And how firm are your boundaries? Do they align with your ethical practice, or are they impacted by hierarchical beliefs and limitations because of other members within your team? Now, I'd love to know your answers, but if it's not something you're happy to put in the chat, I really would encourage you all just to ask yourself these questions, because we cannot work as individuals when we're supporting families. Do you have work to do is another question. Or are you at a place where you feel you're confident in providing culturally competent care? Again, this is a misbelief that has been identified when you speak to women and birthing people. Yes, it's been identified statistically that if a Black mother is seeing a Black healthcare professional, they receive better care. But equally, we're not accounting for the near misses. And I often hear stories of women that have suffered the same obstetric violence from a Black midwife, for example. So race doesn't excuse the need for additional training and reflection or reflective practice. And that was not a trick question. So I leave that thought with you as I encourage you to all reflect on today's discussions and connect further with us for development opportunities if you wish. I'd love to see everyone connect with my wonderful peers, Dr. Rebecca Moore and Illiyin, because I never tire of listening to you and the wisdom that you impart every time you speak. I often meditate or simply daydream and envision cultivating cultural competency as not just attending workshops, but as a continuous journey with peers and colleagues, learning and growing and serving and deserving professionals and good humans. We see growth. So please don't gatekeep any of the information that we share here with you today. I want you to share any key takeaways that you have had today with your teams and your distant colleagues, friends, even enemies, even your family members that aren't necessarily within your sector, as you share a meal together, in the hope that we can be part of a catalyst for change. Thank you. I think I skipped my slides. I do apologize.
Absolutely no need to apologize, Leah. Thank you. That was so thoughtful. You know, the philosophy there of kind of inclusive collaboration, partnership. It's so powerful, but also the sense of needing to kind of put boots on the ground, get to work, you know, take what you've kind of shared with us and do something with it, and be brave with it, even if you're kind of uncomfortable. It's yeah, really encouraging to hear you speak, and I'm so pleased that we've had a multidisciplinary panel. So you were kind of mentioning that you're not a psychologist. I almost made that decision deliberately. I'm glad to have yourself here in your role as an educator, and next up, of course, Illiyin in her capacity as a midwife, but also you know, an entrepreneur, a writer. I'm not going to say any more. I'm going to hand straight over to Illiyin. It's going to be a little bit different because there are no slides here, so I'm just going to spotlight you and give you the floor. Thanks so much.
Hello.
You're just on mute. There you go.
Okay. So I'm very glad to be at the end of my wonderful colleagues because they're so professional in all of their preparation, and I'm just like, what you gonna say? Now, I'm going to caveat this with the fact that I don't prepare for these conversations, and actually, more than anything, I'm seeing what I'm hearing and I'm responding to that accordingly. And it's actually, I believe, from my perspective, in the way in which I teach, the best way to do this, because we are in constant change and there are going to be things that are coming up time and time again, or not. And there could be things that are new to you, probably not very new to me, in terms of cultural competence, safety, advocacy, and racism. So these are sort of areas that I like to kind of really put a lot of work into. And the caveat as well is that as I speak to you, you may perceive that as angry or aggressive or any of these things. And the way in which you perceive the way I speak is actually a you issue. And so I really would advise you to sit with that. It's really important that when being confronted by these things, you aren't sitting in an egotistical space where you are reactive and you decide that actually, you know, I'm not going to be told anything. Like, just sit with it. It's like, it could be uncomfortable. You might not like it, but that is life. You know, there are things that happen that you just don't like, but it doesn't mean that you don't need them. And so in my capacity as an author, an educator, a midwife, but also as a mother, I have kind of navigated this system from lots of different angles. Currently, I work in the perinatal space in the form of birth debriefing, where I invite people to come and discuss their difficult perinatal experiences and kind of unpack those and then repack them, having kind of become more informed, gained a deeper understanding with the ability to reframe their experiences according to how they feel about them. And that is also why I'm very reluctant, because I'm very reluctant to say I am a, I do birth debriefs to help people with trauma, because some people don't have trauma but still need to debrief. And when we look at any kind of perinatal experience, like Dr. Moore was saying, these are like our peak moments. And so it doesn't necessarily mean that we need it to have been traumatic or we need it to have been violent to speak about it. It's just that we need to speak about it. And actually, the first step to kind of working through this life-altering thing that is childbirth is speaking about it in safe spaces. And those are spaces that many of you here work in, and many of you perhaps unknowingly aren't necessarily as safe as they could be. And that's often not intentional. Like, we aren't trying, none of us go into this kind of work to be, to cause harm or to not be safe spaces. And most of the time when we say things like, oh gosh, that sounded traumatic, we think that we're being really helpful. And in actual fact, perhaps we've just planted a seed that wasn't really there. And we've taken the agency and the autonomy away from that person to use their own words to name their own experience. And that's one of the things that I see all the time, when conversations around difficult or traumatic experiences arise. Was it really traumatic though? Was it traumatic enough? Lots of people putting words to things, and language is so important. And I don't think that we are cautious enough. I don't think that we are conscious enough when we use language in terms of saying what we mean. Now, that's not a problem that you're going to have with me because I say what I mean. Doesn't mean that it's always right. It just means that I meant what I said. So what you're going to find here is that I'm just saying what I mean. And you will understand that based on your own lived experiences, your own biases, your own feelings, your own sense of understanding of language. That's a really good example of how we can have misunderstandings, and how we need to examine our own language, our own biases, and our own understanding of how other people speak to us. And when we look at communication is, approximately like 90% nonverbal. And so when we're asking people to use words, it's like, okay, they might say a word, but are you looking at every other form of communication? Because what you might find is that it's telling you so much more than the words do. And many people don't have the vocabulary to put words to experiences. I know that when I had my daughter and it was a horrible experience, I didn't have words to kind of name it. I had lots of long sentences and lots of sort of waffling, but it never really got to the crux of it. And I remember people would say, oh, that was traumatic. And I was like, well, I guess so. But as time's gone, I'm like, was it really traumatic? I don't think it was traumatic. I don't think that I was in trauma. I think I was in fight or flight. I think I was in shock. I think I was in just what is actually a very normal transitional period. And through my experience, I have a lot more understanding of what that looks like. And I was also a victim of bias, stereotyping, and actually poor care. And when I had my daughter somewhere quite, where they don't really like to acknowledge racism, but they're kind of racist, it meant that no one was really looking at that as something that could have contributed to my feelings postnatally. And in fact, there was no acknowledgement of what they could possibly be. And that is where that safety comes in. And then it is at that extra layer of cultural incompetence and, in fact, cultural danger. And this means that I go into this space and it's like, okay, yeah, I'm going to speak about my experience, and there's nothing. In fact, there is harm. I remember when I had my daughter, I had a midwife that looked after me, and she wasn't very nice, and she wasn't, she contributed a lot to the feelings that I had postnatally and about my birth. And then when I had my son, in a very positive experience that I had agency over and had really dedicated a lot of energy to, I went back to a clinic appointment and I walk in the room and there's this woman. And I thought to myself, oh, look, there you are. And she said she didn't recognize me. which is an important point. She didn't recognize me, and she starts saying, oh, what do you do? Da, 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 da. And I explain, I'm a midwife, but I'm working in the sort of, you know, perinatal space for sort of processing difficult experiences. And she goes, yeah, there's so much trauma out there, isn't there? I thought to myself, you cheeky bugger, what you did to me, you have no awareness of. You have no awareness of. You don't remember me, and you have deeply impacted my life for a period of time and the decisions that I've made and how I have navigated those early years of childhood. And you do not remember me. The audacity. And I had a rise up of this feeling of like, bloody. And then I thought, you know what, it's fine. She's actually irrelevant. And the reason I'm telling you this, and what I'm saying is really important, is that you hold pivotal spaces. You will be remembered by the people that you can either help or harm. And I want you to think about that when you're giving advice, when you're using language, when you're signposting, when you're giving diagnosis, when you are culturally competent or incompetent. I want you to think, this person will remember me. Now, I quit my job. I suppose maybe like on a whim, I don't know. I was involved in a traumatic situation that I know was traumatic because it was traumatic for me as a person that's feeling it. I have put those words to it. And I looked up at this woman's face, and she was looking in my eyes, and she had really wide eyes and fear that was right there. And I think I probably had the same look, but how reassuring is that? And she said, and I said, I can't do it. I can't be this person's memory. I don't want her to look back and see my face every time she thinks of a negative experience. And so I don't partake in that anymore. What could potentially be perceived as negative, if I have any power over it, I do not want to partake in it, and I don't want to be a negative memory. And so we have to look beyond the immediate information that we're giving and say, hold on, this impacts someone's life for a prolonged amount of time. So what am I going to do here? Now, in order to do that, this takes reflection. This takes humility. This takes some deep digging. And sometimes we just aren't going to like it. We're not going to want to go there. We don't want to know that we may have caused harm and that we may have said the wrong thing unintentionally. But unless you do that, you will always repeat the same thing, and you will always be that memory. And I don't think any of you want that. Now, the thing is, when I say language is important, I mean that because what we've done, and it's really kind of, it's quite impressive. We have diluted the issue of racism in the perinatal space by referring to it as unconscious bias. Now, unconscious bias is a thing, but you can only be unconscious once. Because if you're doing what you're supposed to be doing, you're reflecting. And if you're reflecting, you bring it to consciousness and you don't do it again, or you change it, or you do it again because you're like, hold on, upon reflection, that was a really good thing that I did there. So this whole like leaning on unconscious bias, oh God, that was harmful, but it was unconscious. Oh gosh, yeah, I was racist, but it was unconscious. It's something that is done for the person, often the white person. And I say the white person because if we look at, as Leah mentioned, those power dynamics that exist when we live in a society where the dominant race in most areas is white, means that you are going to you're going to be taking advantage of those privileges, the privileges of the unconscious one. It's how we can be flustered and be, oh, whoopsie daisy. Whoopsie daisy is very harmful for the Black or brown woman that you have said the wrong thing to, that you have been a culturally incompetent space for. It's no whoopsie daisy because you forget it, but we remember. And so you have to be aware. The only thing I ask of you, I don't ask of you to become a professional. Like Leah was saying, I'm not saying to you that I want you to be like, oh my gosh, I'm not racist. Da, 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 da. I don't even want you to be defensive. I mean, you can, but you know, I don't know, talk to your friends about it. Like, you know, that's not really it. What I want for you is to go, okay, consciously, I'm not racist. And I really hope that that is the case, because we are dealing with a multicultural society where we are seeing lots of people from lots of different ethnicities, backgrounds, cultures, practices, spiritual beliefs, faiths, and so on and so forth. But I want you to think on a conscious level, I'm not racist, but unconsciously, there could be things that I could do better on. And that's all we want. You know, we want to do better. We want to do better for ourselves, and we want to do better for the people that we serve. And if we have come to the point where we don't want to do better for the people that we serve, then it's often better that you just jump ship. You know, it's not worth it for you, and it's not worth it for them. Now, this leads me to my final point, and I'm really not aware of the time, so I'm sorry. My final point is you have to think about yourself. Now, if I think of myself at the center, and I am at the center of my world, and that's in the center, I'm talking right at the heart of it. My children aren't there, my husband isn't there, my work isn't there, I am, because everything stems from me. Everything I put out and everything that I do is coming from me, right? So if we're staying in that center, we have to look after the center in order to be able to do better for everyone else. So center yourself and say, hold on, I'm taking on too much. I might be causing harm. I might be harming myself. This is where that self-advocacy comes in, because if we don't, we burn out and we cause way more harm. But not only do we cause harm to those who are around us, we cause harm to our center. And I'm sorry, you guys might get paid a lot more than I do, but there is no amount of money that is going to make me say, but that's fine. It's okay. It's not okay. So if you're in your job and you're like, it's not okay, I'm not okay, this is taking more than it's giving and it's harming my center, I really want you to sit and think, well, what am I going to do about it? You know, and in that centering comes everything else that I've spoken about, that reflection, that growth, that change, that kind of thought of, am I providing cultural competent care for all of those that I'm serving? Am I signposting in the right way? Am I understanding language? And am I understanding communication? And am I trying to constantly be in change? Answer those questions for yourself. See what answers you get to, and then go do some work. Thank you.
Lean, thanks so much. An unapologetic reminder, I think, to kind of acknowledge, you know, the inequity in the distribution of power structurally, but also kind of in terms of relationships within healthcare organizations between therapist, client, doctor, patient, and the need to kind of, yeah, get curious with people's perspectives, empower people to kind of co-construct treatment plans, narratives, without making kind of assumptions and just kind of writing it down for people, but also kind of a reminder to look after oneself as a healthcare provider working through organizations in that, not least because you are at risk of doing a hell of a lot more damage if you don't. So there's kind of accountability to yourself in that, but also kind of the people that you look after. My best attempt at summarizing what was just a wonderful kind of 20 minutes and 20 minutes before you from Leah and the context that Rebecca provided right at the start. I can only apologize to you all, I think, in kind of setting you the mammoth task to kind of give us an introduction to perinatal mental health, and then also kind of invite us to, yeah, enhance our reflective practice and lean into kind of parts of, yeah, our work that might be or likely are real blind spots to us. I mean, we've got 12 minutes. We've had a couple of questions. I wonder if I can kind of spotlight all of us. I don't really know if it works like that. Yes, add spotlight. There's Leah and Illiyin. Let me add Rebecca. I think I'll just stay small and give you guys the spotlight. We've had a couple of questions. I mean, I had one or two that were burning for you, but I wonder if we prioritize the voice of the group. This one's for Leah. Ruthie asked whether you'd helpfully clarify what you mean by obstetric violence. You know, what's the definition of that? What does it kind of look like? You know, how can we maybe reduce the, yeah, go on.
Good effort. The term obstetric violence was coined in Venezuela back in 2007 as a legal term to describe abusive practices in birth. It's a form of gender-based violence that occurs all over the world in both high and low income countries. It's not about obstetricians at all. It's about the intent, not the profession. It's about the sex or gender of the victim, not of the abuser. And it's essentially disrespectful maternity care that is rooted in patriarchal and white heteronormative power structures in medicine with a documented history of racist practice and paternalism. Does that help? I think when I said earlier on that it's not just physical violence, that it's emotional, mental. It's also the one that I've added at the end was written because it dawned on me. I think I was running a training for South Wales, and I was reminded that actually how we, or how midwives specifically, sorry, Illiyin, document people's birth experience according to their views and opinions and their perception, it can be a form of obstetric violence because it's essentially an opportunity for them to pass blame or deny the fact that they may be complicit in an act that has been harmful or traumatic for the woman or birthing person. Sorry that took so long.
No, thank you, Leah.
Look at, you know, just to kind of carry on that. In my work, I say to people, don't, you know, when they say, can I get my notes? And I'm like, just calm down, because sometimes they can be really harmful if we think of those notes as a legal document from a person that is ultimately having to protect themselves against the bureaucracies of the system, which are, you know, that is a struggle in itself, but their sort of responsibility is self-responsibility. And so as they document, it will be, whether conscious or unconscious, a way in which they will protect themselves. So in that way, there's going to be quite a bit of violence in it. They're not going to say, no, I didn't let her get water. No, I didn't listen to her when she said that she was in pain. They're not going to document that, because in a court of law, if we look at obstetrics being one of the biggest areas of litigation, we know the biggest. There we go. It means that they're going to do anything that they can to protect against it. Sorry, I just jumped on the end of that.
No, I appreciate your input.
Thank you both. Rebecca, did you have any reflections to add to that, or should we move to another question?
No, I think that's been beautifully explained. So let's go on.
Oh, lovely. We've had a couple of questions. I mean, I wondered if I could open this up to the three of you, but we're a group here of, say, 60, 65 kind of CBT therapists, psychologists. That's who I imagine is kind of here. And I just wonder what steps can a psychologist or a therapist take in kind of integrating a much more culturally safe approach to building early therapeutic relationships, I suppose in your context, specifically in the perinatal setting, but just generally. What are your thoughts on that?
Listen.
I was just going to say that, Leah. It's really easy.
Yeah.
We do not have to overcomplicate it. Like Leah said, like Illiyin said, you don't need to be an expert in everything. You need to listen to the person.
And it's to follow that up. It's like,
what do they need? It's not what I think they need. What do they need? What can we create together that feels safe for them? I'm not there to tell people what to do. I'm there to listen really hard. And I've said this millions of times before, but listening is a really underrated skill, and doctors are the worst. There's loads of literature around how doctors interrupt people on average after 60 seconds of them talking. So we really need to shut up, particularly as doctors. And it's not complicated. You need to listen to people and work from there, would be what I would say.
Totally. I'm sorry for interrupting you. I'm not even a doctor. That was rude. You know, I think as to kind of like just go on the tail end of that, which I seem to keep doing, is listening to hear, not to answer. So I think a lot of the time when we're listening, we hear like 3 words that might stand out to us, and then we answer what those 3 words have created in our minds. But if you listen completely, ready to just hear, and then to go, okay, now I can answer because I have allowed you a full sentence. I have worked that through in my brain and I can answer what you're actually asking. You do a lot better. you know, a lot of the time. And I think particularly here in the UK, we're very much like, we want to fix things. But as humans, we always want to fix things. And sometimes people do not want us to fix things. Like, you know, some of these power dynamics and things like that, they can't be fixed. So it's like, don't try and fix it. Please, I'm not looking for solutions. I'm not looking for plasters. I just want you to hear me. You know, it's kind of a very, in a sort of heterosexual couple, you'll find a lot of the time husbands or male partners will try and fix everything. And on like a personal note, my husband and I said to him, do you know what? I just need you to ask me when I tell you something. I just need you to ask me, do you want a solution or do you want to be heard? Because then we can just have a conversation. And if that's what you're doing with your clients, even if you're not explicitly asking them that, but you're thinking, hold on, I'm listening, and then I'm going to look at what they need based on what they are telling me, you'll often know whether it's a solution or just to be heard.
Can I add to that? I'll keep it really quick because I see the time. But also showing them that you're removing the hierarchy. That's something that's come up time and time again. And it's almost the more qualified you are to help individuals, the higher up they see you in the food chain, which the lower down they then see themselves, which is equally as damaging. So if you could just highlight that verbally and remove it, I believe that's fairly helpful.
I've just seen this question come up here at that. I'm sorry, maybe you were going to actually talk about that. I've just read it and I'm like, oh no, the time's running out. You're not going to get an answer.
Go on, take the lead on that one. What was the question you spotted that you were going to respond to?
Yeah, it's this one about self-disclosure.
Yeah, go on.
I think it is, you know, it can be a really brilliant tool to create trust. But I actually feel that unless we have worked through a lot of this stuff ourselves and have it really figured out, it's probably for the best to not, you know, because actually we can extend compassion and empathy without needing to be relatable. You know, I think we use relatability as a tool to create trust, but actually sometimes it can be really harmful. It can actually break down that professional partnership and that trust in your kind of diagnosis or perception of the issue, because suddenly they know a little bit too much about you and they're like, oh, and you don't know what they want to know about you. You don't know what they think is relatable. When it comes to things like religious differences, they do not need to know, because that's not your space. That's not your space, it's theirs. So in order to create that safety, you have to go, well, this is actually your space, not for me to impart like my feelings or opinions, even if it does make me more relatable. But read the room, you know, it's always, you know, we really, it's case by case, but generally, having done a lot of self-disclosure in my early days of my job, I would definitely recommend not.
I don't think I need to add to that at all.
Yes.
But Alice's question, how do you separate out the issues of culture and race from poverty and social deprivation across the spectrum? Why is that your role? Would be my question back to you. Because being Black doesn't make us poor, and being poor is not unique for only Black or brown people. So actually they separate themselves. It's the stigma and the stereotypes that put them together. So again, I use this word far too many times in the space of 90 minutes, but it's your perception of how you define those things.
And also, you know, in terms of, you know, bias and harm that is caused by Black women, but also to Black women, is that actually we know that socioeconomic status has nothing to do with it. We know that it is not one of those factors that bears any difference in terms of how to those statistics. So it's like, oh yeah, they might be poor, they might be rich, but still they are going to have issues that happen to Black and brown women. And like Leah says, it's like, people have put them together. If you're poor and black, if you're this, you know, if you're poor and brown, but it's like, it's got nothing to do with it. These are separate things that have their own issues and their own stigmas attached to them, but it's important that you separate those stigmas, but that you've done sort of, as we've all said, that reflection and looking into where that thought even came from. I'm not reprimanding you at all, but it's more like, interesting way of phrasing that question, why have those things come up together? And see if you can just break that down.
Any research on connection between previous trauma?
So I'm really aware that we've just broached 8 o'clock. I mean, I think it's partly my problem. I think my ambition was almost too large, which is perhaps something for me to reflect on. But as a psychologist myself, as a practicing clinician, I'm just so grateful for the three of you kind of coming together, giving your time so freely to us this afternoon, you know, to remind us of the importance of treating people with dignity, respecting people's histories, celebrating joy, honoring hope, using humor, being curious, the simple stuff that you'd hope every therapist, you know, just has in their arsenal. But how do we kind of apply it reflexively with an awareness of implicit bias, but only once, because after the one time it's no longer implicit, which is something I'm going to take away from Illiyin. And I know that other people in the chat here are kind of talking about little things that have stuck with them, the comment here around spiritual violence, and I suppose we couldn't have hoped for anything more than that. Just some things to kind of take away and reflect on. I know I've kept you past 8 o'clock. I did want to plug Make Birth Better as a tremendous charity. I am going to put the donation link in the chat. I mean, the three speakers here, of course, have given their time so freely this afternoon. I would be not doing my job if I didn't kind of just gently encourage people to maybe think about providing a donation to Rebecca's charity, or to kind of think about leaning into continued professional development with either Illiyin or Leah or Rebecca as they work together as a team so often. I know I've gone over time, but I also don't want to be the person that has the last word. So I just want to hand it back to the three of you. I don't know, something that you'd hope that we take away, or a final reflection from you all before we kind of pull the session to a close.
Becca.
Thanks. I mean, I think like it comes back to listening again, and don't underestimate the skill of that. You know, that it doesn't need to be complicated. We need to just listen. And I think it was something that Leah said, and you know, just this sense of this is a lifelong thing, right? This is, you know, something that we should be all tapping into and questioning and learning. And this is not something you kind of do once and tick, it's done. It's that kind of lifelong learning of being trauma informed, you know, for me is something that I feel is really great as part of that. It's an ongoing thing, and that's actually really helpful for me to continually hold in mind.
And don't forget that you're human.
Yeah.
You may be a therapist, psychologist, psychiatrist, but you're also human. And we don't want you to not get it right, but equally, you will get it right eventually if you have the passion and the compassion to do so. So if you make a mistake along the way, it's okay. Not too many, but give yourself grace.
I think my final point is, because I covered numerous sort of things, and actually it really comes back to those intersections, that lots of things exist alongside one another, and there are going to be people that tick certain boxes and don't tick others. And you know, particularly as we move more towards sort of algorithmic work, we are sort of thinking everyone kind of can go a bit like this, when really we're sort of like, you know, if you were a teenager, when I was a teenager, when you'd have magazines and it was like, yes, go right, no, go, you know, it's like those are our intersections. Like, we are complex beings, we are multifaceted, and we can't go in straight lines. That's for you as practitioners and your patients and clients. So, you know, really kind of move away from that kind of really lateral way, and recognize that it kind of is a bit more like this, or however you want to see it.
Pick over the box.
Yeah, basically.
Thank you, Tom, as well. Thank you to you.
Yeah.
Not at all. I mean, I think I probably speak for absolutely everybody in the chat when I give you just a heartfelt thank you. It's been really thought-provoking for myself, and I'm sure for everybody else as well. Thanks so much for all that you do. All the best with the summit that's on the agenda. Is it in the summer, Rebecca, or is it?
It's May the 14th
May.
and 15th.
It's a great summit, by the way.
You should all go.
Yeah.
Everyone should go, yeah.
It's only £35. Plug
Really
for 2 days.
As well. And we're both champions as well.
Yeah.
Yeah, before I even met you, Rebecca, I didn't realize that you were such a super team, but just by chance I've happened upon the three of you. It's been brilliant. So I really do wish you all the best now this year, and thanks so much. But I think we can bring the session to a close.
Thanks, Tom. Take care, everyone.
All right,
Bye-bye.
thank you everyone for coming.
Yeah, so thanks so much for attending, everybody. The session will be recorded and it will be made available on the Associate Shared Drive. So if you did want to kind of go back over things or kind of listen again to the talk, you'll be able to find that in due course. So thanks so much for attending. Take care. Bye-bye.